in this era of COVID-19 with the pandemic, it has certainly accelerated many of the things that we have been instituting in our clinics, but also emphasized the importance of switching whenever possible and feasible to oral therapies. For example, in the metastatic setting in colorectal cancer, instead of using FOLFOX, use CAPOX, so capecitabine and oxaliplatin. And whether going through any of the regimens, FOLFOX, FOLFIRI, or FOLFOXIRI, switch to a maintenance strategy within 3 months following initiation of the combination chemotherapy with capecitabine and bevacizumab. Bevacizumab is given every 3 weeks, so that minimizes how frequently the patients are going to show up to your infusion center, but also because of the relative safety with this regimen, the ability to essentially minimize visits, and many of the visits can be transferred into telemedicine and telehealth. And so 3 months of FOLFOX, FOLFIRI, or FOLFOXIRI plus bevacizumab followed by capecitabine, bevacizumab. There's ample data to support essentially doing this without not only not compromising patients' outcomes, but optimizing their quality of life and their likelihood of survival and progression-free survival. In the more refractory setting, we have 2 oral options essentially available to us. We have regorafenib and TAS-102. My preference is to go with regorafenib primarily because it's less immunosuppressive. So again, for patients who now we know are at a much higher risk of dying if they contact COVID-19, we want to minimize the risk of immunosuppression. And so using regorafenib with a dose optimization strategy, starting at 80 to 120 to 160, with follow-ups by telemedicine, telehealth, would optimize actually its use, its lower likelihood of toxicity, and maximize its potential benefit. So overall, in colon cancer and the metastatic setting, we shifted to that strategy. In the adjuvant setting, capecitabine plus oxaliplatin is preferred over FOLFOX. We've seen data now from ASCO that does, again, emphasize that 3 months is more than enough, and capecitabine plus oxaliplatin given every 3 weeks gives you the same outcomes than 3 months, whether you're high or low risk. So overall, the shift is happening, seeing more and more of these oral therapies in the adjuvant early stages, and in the refractory setting, regorafenib, TAS-102. And again, as I said, my preference would be for regorafenib with a dose escalation strategy.